Charles Shaw, Mr. Accreditation, but he's not dealing with accreditation only. He was he worked in the Bermudas, then he decided he likes cold weather better, and so he went to work both in Great Britain and other. Then he worked in the King's Fund, and he worked for many administrations, many governments, and many activities. I leave him the floor, thanking.
Buongiorno tutti. Thank you, Andrea, for the introduction. What I'm going to say is not very different from what Hanu has just said. Indeed, I was lucky to be at the King's Fund in London in the early 80s, 1980s. And one of the things I did was try mapping what are we doing in this country on quality in healthcare. So I asked the Royal Colleges, I asked the regional health authorities, I asked various societies, and began to build up a picture. And I came to the conclusion that quite often, if you ask an organization, at least if you did in those days, do you have a quality system? They'd say no. But if you ask them a few specific questions, the answer is yes, but we hadn't thought of putting it together into a system. We were rocketed into a thing called, we call it medical audit, not through good professional leadership reasons, but because Margaret Thatcher produced it as part of a white paper in 1989 and said, this will be mandatory for all doctors. And this accelerated things. But I then moved off from medical audit into perhaps healthcare accreditation, including at the King's Fund. And then when I became increasingly useless in the National Health Service in the UK, I started working outside the UK. And one of the things which I started doing was, well, one of the successors to Hanu in Copenhagen WHO office was a guy called Isuf Kallo, who is a hematologist, Albanian. And he was the regional director, I think it was called, for quality assurance. It's two successions after Hanu was there. And one of the things that he asked me to help him with was to go visiting countries to assess how their quality systems were. And to do this, we produced a sort of a little map. We developed structure, just 4 pages of specific questions about what you do in quality. And essentially, we were looking at a variety of things. One, you'll see this cycle is very common, although the American version has 4 stages: plan, do, check, act. But basically, it is where do you want to be, what should you be doing, what are you actually doing, and how are you going to make things happen. And this is what's usually left out in most quality systems. People get preoccupied with the standards or the assessment. The mapping, as we started calling it, in this book, which is still available online from WHO, my name and Isuf Kallo, K-A-L-O, it's called, I think, A Background to National Quality Policy. But essentially, there were 4 headings. One is, do you have any policy? What sort of legislation do you have regulating institutions, regulating professions, regulating staff safety, for example? What sort of organizations do you have who deliver this, both within frequently the Ministry of Health or regional health authorities? What about the academics? Where does it come into the teaching curriculum? Professional associations, what sort of role do they take? And I don't just mean doctors. And also, have you tamed the international community? This is a big problem in many countries, not so much in the West here, but if you go to lower middle income countries, many of them are at the mercy of policies that are imposed on them from outside. Then a series of questions about How do you do these things? Do you have ISO certification, accreditation, licensing, regulation? What about patients and the public? How are they involved? How do professions develop in terms of what's the career pathway, etc.? Who looks after clinical practice? Is it left to each individual, or is it actually in some way guided from where? And then there's a question of safety, risk management. The last section is resources, and I don't mean money. It's what resources do you make available to quality improvement in terms of data, information systems, examples of how to do it, training for improvement. And one thing we found a big issue in the UK was, do you actually have any time in your normal working life to sit down with your partners, or not partners, your colleagues, to discuss performance? So anyway, that was the basic, that's the outline of the mapping criteria. And I won't go through these in detail, but I just to say I have used this in several places. And on one occasion I was asked by Pan American Health Organization to go to the Caribbean, where I started really. And it's interesting that each of these relate, you probably can't read them, to one of the criteria, and these are the ones where nearly half of the countries said yes, we got a handle on systematic methods of improvement, but almost nobody actually seemed to have any budget for this. External assessment like accreditation, certification was really not organized at all. There's nobody seems to be in control of it. So I'd just say you can try it. I'm just rather embarrassed to realize that the footers on these are all a bit miscellaneous. This goes to show that I find these slides keep cropping up. Having done this assessment in any country, and I would suggest you could probably do it in an Italian region as well, it's one way of taking stock of what the values are of that country. What is it that people actually think is quality? Are we agreed on that? We could then map what policies exist, and many countries actually, they don't have an explicit policy, but you can interpret from what laws they have that there must be some intention there within the Ministry of Health, for example. So looking at the laws also gives you an idea of what the thinking is. You can then find out what existing mechanisms are there. What I've tried in several countries is then setting up some working groups, because the trouble of doing this as an outsider is that it's an external thing, and you don't actually involve the people in the country. So I find by setting up 5 working groups, I've put them into these groups. One is what you do about patients, patient information, public information, patients' rights. Second is how do professionals actually develop everything from undergraduate to continuing education. How do institutions develop? And this is where things like accreditation, organizational audit can be extremely helpful, ISO certification possibly. So that's about developing the institutions. Many countries don't really have any management system. Institutions are frequently run by doctors who have absolutely no training in management. It's assumed because they're doctors they must be good at everything, and I think that this shows in many countries. Then the question about clinical practice: who defines what is good medical practice? How do you measure it? How do you monitor it? And then after those 5 working groups, we had another one which looked at the outcome of the previous ones and said, okay, what does this mean for our health system? I'll give you an example from Moldova, where we've recently done this. Again, through the offices of WHO, the country office. We set up the stakeholder working groups. We gave each of the working groups a fairly good briefing paper saying, look, this is where you seem to be now on this issue in this country, and this is where Europe, the world, and other people have done similar things. So would you like to think about it? And then we had one pulling it all together. We've drafted a report and made some recommendations, and this was all timed very carefully to be just before the next election. One of the difficulties of introducing anything, as I'm sure you're all familiar, is how long will the ministry remain? How long before this minister moves, policy changes, or there's some reversal? So I think one of the arts of actually making things happen in a country is making whatever you propose acceptable to either this party or that party or all parties. So during the preparation of this report, we were quite deliberately talking to everybody we could, all the deputy ministers, the minister's friends, the minister's enemies. So with a bit of luck, no matter what happens in the election, you still have some support. I can't guarantee it always works. I won't go through the details, but I'm saying that particularly in a lower middle income country, this sort of systematic analysis can be really fruitful. Because one of the biggest problems, I think, in that sort of country is the culture. It's a culture which is post-Soviet by habit. It's used to the top-down instruction rather than any sort of leadership from professions. And essentially, I think you could say, to be safe and quiet, everybody ignores everything. You try not to listen. You don't take any responsibility. You don't volunteer anything. So to change that sort of culture takes a long time. And I have seen it change quite rapidly, say in Hungary and in Poland, where initially doctors in particular would be completely passive. You could not get a reaction out of them. Slowly they started discovering that actually there's something to be said for self-regulation. So one of the things, and I was interested, Hanu mentioned legislation. It's a characteristic of, and I would say this is certainly true of the Balkan states, I've worked there quite a bit, and in post-Soviet countries, that everything starts with a law. So, the tram lines have been laid down by lawyers who frequently have very little understanding of what it is that, say, accreditation is for or performance management is for. There's a law, and then you have to try to make the law work. So one of the first things we did in Moldova was to agree we're going to have to review the legal framework to fit in with the reality and what is practical. Second thing, we had to agree that we were all working to the same general principles of what is quality and quality improvement. The clinicians thought it was about, having access to better drugs for management of myocardial infarction. The health insurance company thought it was all about increasing access to health care. Nobody was interested in whether it was safe or not. So through this process, we've begun to realize that everybody seemed to have a different version of what they were doing. One key issue which I was pleased was accepted quite quickly by both the Ministry of Health and politicians generally, and the professions and the regulators, was that we've got to get out of the habit of inspecting everybody and start getting into the habit of trusting professionals to take responsibility for themselves, to communicate with patients, to apply peer review, self-audit, in order to balance the top-down direction. But that does take time. The other issue was, again, typically post-Soviet setup, and in many countries who've never been anywhere near the Soviet Union, control or quality is about punishing people who get it wrong. a disaster, a mistake, and the heavens fall in on whoever was the unfortunate person who was involved. And the whole assessment process of, say, the accreditation program was to find non-compliances, to find failures, and to make a fuss about the failures. And I've tried to persuade the Moldovan government, and I say I've done this in various other countries, to start celebrating the achievements. Use your performance indicator system to demonstrate what you have achieved and not just what you failed to achieve, which takes quite a difficulty. And then to link that into the financing. So another common problem with the development of universal health coverage is how do you actually relate performance to payment? The discussion is going on. So we're really talking about successes rather than failures. I'll leave the second one. But just to finish with this slide, which takes a bit of getting used to, but essentially it's where I started with a set of standards, measurement processes, and an improvement process. Standards essentially come from technology assessment, biomedical research, they come from patients' rights, they come from organizational standards, which we'd like to think are evidence-based, like for accreditation. We've got lots of measurement systems, but what I'd like to focus on is the impact of these different bodies. And I think if you map them, so, okay, where do they come into this quality cycle? The key one probably is financing. Do health insurance funds actually reward and encourage improvement? We've got issues about, in the medical schools, and again, Hanu mentioned this, does the undergraduate actually get equipped with the ability, the knowledge of how to measure anything? And I certainly found in the UK, it took our Royal Colleges nearly 10 years after Margaret Thatcher said, you will do this, before they introduced it into their curriculum. So, and I think there's a long lag time. Then we've got management processes. How good are they? Are they channeling and pushing in the same direction? A major problem of many countries is that what data are collected just go into a big black box in the ministry. They're never actually analyzed or fed back. It seems to be just a, as I say, a black box. It just vanishes. Then we've got consumers. They can come into the whole process. Again, Hanu mentioned the use of clinical guidelines given to the patient as well as to the professionals. We've got the role of the professions in leading. And again, obviously in Finland, this has worked well. I found it very useful in the UK. Once the doctors realize they're going to have to do it, and I said, well, either you can be pushed or you can lead. And they then decided we'd rather lead. So they did. Accreditation, etc., and Ministry of Health direction. What I'm really trying to say in this is all of these things need to be working in the same direction. And in so many countries, you find they're actually heading in different directions, which is why it often doesn't work. I'll stop there, because I think we're going to finish this meeting at about 4 o'clock anyway.